So we are on live and we are starting the session, sir. Yes, sir. So very good evening, doctors. I am Dr. Stalin on behalf of Shield Healthcare, welcoming you all for today's webinar on Pelvic USG Updates, organized by Fetal Medicine Committee, AMOX, and Aurangabad Obgyn Society. I welcome the chief guest, guest of honors, speakers, chief guests, and chairpersons for the today's session. I take my pleasure to introduce the MOC for today's session. Can I have a CV, please? Saiti.
Yes, sir.
Yes. I need doctors. Yeah. So, Dr. Swati ma'am, madam is currently the consultant and obstetrician gynecologist at St. Anne's Hospital, Aurangabad. Madam has done her MBBS, MS OBGN, and DNB OBGY. And madam has held various positions in the past as registrar and won various awards to her quiz. And madam's special interest is high risk obstetrics and infertility. So, with this short introduction, I welcome you, ma'am. Mandatory session to you for your further proceedings, ma'am. Thank you, ma'am. So Swati ma'am has left, I guess. Swati, we can go to the next slide, please. Yeah. So now I would like to introduce our convener for the today's session, Dr. Sujit Kondakar, sir. Sir is the chairperson, Fetal Medicine Committee, AMOX. Can I have our sir CV, please? So sir has done his MBBS MD OBGY from GMC Aurangabad. Basic USG training at Dr. Bimal Shahani's Sonoscan Center, Aurangabad. FMF certified for 13 week scan, a PE screening, and Doppler ultrasound and fetal abnormalities. Secretary of Society of Fetal Medicine, Marathwada chapter. His Sri Hospital is Foxy approved ESG training center, interested in advanced fetal ultrasound. Chairperson's Fetal Medicine Committee, AMOX. So we welcome you, sir. I welcome you to address the session, sir.
Thank you, Dr. Stalin. Good evening, my dear friends, colleagues, and seniors. I am very much delighted to welcome you all. I welcome our chief guest, Dr. Madhuri Patel, Secretary General, Foxy. Ma'am, your words will be valuable for us. Welcome our guest of honor today, respected Dr. Rajendra Singh Pardesi, sir, President AMOX, and Dr. Kiran Kurtukoti, sir, Vice President AMOX, for this webinar. I welcome our esteemed faculties, Dr. Anirudh Kulkarni, sir, and Dr. TLN Praveen, sir, who will going to enlighten us with their immense knowledge in pelvic sonography and related subjects. I welcome President Anjali Vare ma'am and Secretary Vaishali Surase of Aurangabad Obgyn Society for this webinar. They are also making a role as chairpersons. I welcome all delegates who have logged in for this webinar. And about today's webinar, there are three talks. First one is going to be on very basic pelvic ultrasonography methodology and common and some very common abnormal findings. Second talk is going to be taken by Dr. Anirudh Kulkarni, sir, on imaging modalities in tubal ectopic with their ablation. And third talk is very interesting, which is going to be taken by Dr. TLN Praveen, sir, regarding non-tubal ectopic current concepts. So over to you, Swati, about further arrangements.
I welcome today's chief guest, Dr. Madhuri Patel, ma'am. She is Secretary General, Foxy. Welcome, ma'am. She is Secretary General, Foxy, Joint Secretary, Foxy 2009. She is a committee member, FIGO, Preetamberg, Associate Editor of Journal of Yogi, Honorary Clinical Associate at Nauroji Wadia Hospital. She is Honorary Consultant at Police Hospital, Mumbai, Visiting Consultant at St. Elizabeth Hospital. She is a former professor and HOD at ESIC, Mumbai. Awarded MOGS Dr. Shailaja Narayan Pandit Award. She delivered many guest lectures in many national and international conferences. She has more than 50 publications in national and international journals, and she has Foxy award-winning book Gynecological Cancer 2007. Welcome, ma'am.
Thank you, Swati, for your kind and generous words.
respected our AMOX President, Dr. Rajendra Singh Pantresi, and today's guest of honor. Then Dr. Kiran Kurtakoti, Vice President AMOX, again guest of honor. Then Sujit Konkar is the Chairperson of Fetal Medicine AMOX. Dr. Anjali Vare, President of the Aurangabad Society. Dr. Vaishali Surashe, Secretary of Aurangabad OBGY Society. I can see speakers, Dr. Anirudh. Then one more speaker, this one I saw, Dr. Praveen. And of course, third speaker is our Sujit, all the chairperson and all my senior and junior. Very good evening to all of you. At the outset, I would like to thank organizer AMOX Aurangabad Society, Sujit, for giving me this opportunity. As a Secretary General of FOXI, I take the opportunity to say something about FOXI because AMOX is part of, FOXI. Aurangabad Society is part of FOXI. So we are all together. But still there are members who have joined, they are not aware about certain things. So I would like to mention as that FOXI is the most vibrant, prestigious, and one of the largest OBGY professional organization of the world with 263 member bodies and 38,000 plus committed members for the women's health. And as I mentioned that we have mission, then mission is that we have to protect our and support our OBGY practitioner in India. Secondly, we always believe in educating and disseminating the knowledge and research. Thirdly, FOXI serves to advocate the cause of reproductive and the sexual health of the women. And most important is reduction of maternal mortality. That is our primary mission. And I'm happy that all amongst all these societies are on the same page to fulfill our mission. Then I must say that today's topic, very important, basic in sonography. As all of us are aware, the sonography was introduced in 1958 by Ian Donald and his team from the Glasgow by publishing the article in Lancet. So now, today it is all of us, it is impossible to treat the patient or diagnose the patient without the ultrasonography. And so all of us have become sonologists by default. And for that reason, because we are practicing sonography, we are practicing OBGY. I was talking to Sujit, are you only in sonography? So he said, no, I'm also doing OBGY practice. So I'm happy to know that. And therefore, when we are doing sonography, we have to know at least, not everything, but at least basic knowledge of the sonography, so we don't miss out. The second topic is about the ablation therapy by ultrasonography. And I went through that, Dr. I think Anirudh is going to talk, and it will be very interesting because the focus sonography, I don't know whether you are going to talk about the focus sonography, but when you said ablation therapy, what I read, that it is a beams, which are passed through the sonographic beams, which will only, destroy thermal destruction of that tissue which you wish, right? And the other normal tissue remains, it is not disturbed. So this is very, very early, non-invasive, treatment. So I don't know, Dr. Anirudh, I'll be there for your lecture. I'll be traveling and I will learn more. And third, of course, the topic is non-tubal pregnancy. As you know that 95% of the ectopic pregnancies are tubal pregnancy. 5 to 8% are non-tubal pregnancy. And Dr. Praveen, it is very challenging to treat non-tubal pregnancy. Because in the past, when we were resident, I was lecturer, Dr. Rajendra knows it. We used to get the patient, in the state of shock because of the ruptured ectopic. But nowadays, because the women's education standard has improved and women empowerment has, patients are coming to us as soon as they miss the period. So this is the best time to diagnose ectopic pregnancy, whether it is tubal or non-tubal. And we can give the best. We have now modalities like sonography, beta HCG, so we can diagnose and we can prevent the maternal and morbidity and mortality. And Dr. Praveen, we have experienced the patient comes with the bleeding PV and patient keeps on bleeding in spite of curative, then we have to think it is a cervical pregnancy. Nowadays, the scar pregnancy rate have also gone up because of the cesarean section, and there is lots of problem, and we have to treat our patient as diagnose and treat them as early as possible to benefit our women. So we have now today galaxy of eminent speakers. They are going to tell us, they are going to enlighten us about the topic, which will help us in day-to-day practice to benefit our women. So I congratulate amongst the Aurangabad Society and Sujit for the most apt webinar and wish you best luck. At the end, I would like to mention quote by Nelson Mandela. Education is the best weapon. When used, can change the world. So dear friends, please educate ourselves, with update our knowledge and give the best to our women. Thank you once again for giving me this opportunity.
Thank you, ma'am. Thank you so much for your kind words. Next, I'll welcome today's our guest of honor, Dr. Rajendra Singh Pardesi, sir, who is the president of AMOX, and Dr. Kiran Karkote, sir, who is the vice president of AMOX. Welcome, sir. Dr. Rajendra Singh Pardesi, sir.
It's okay. It's okay, Swati. It's okay. We can skip this. Good evening, everybody. Respected chief guest and our motherly figure, Dr. Madhuri Patel, ma'am, and our AMOX Vice President, Dr. Kiran Kurtkoti, AMOX Chairperson of Fetal Medicine Committee, Dr. Sujit Konkar, and friends. First, I wish to congratulate Dr. Sujit Konkar, Dr. Anjali Vare, Dr. Vaishali Surase, along with active MOC, Dr. Swati Parihar, for organizing this webinar on sonography. As all knows, Dr. Madhuri Patel told, sonography is our third eye, or you can say it's a stethoscope in our day-to-day gynae practice. AMOX is committed to this mission to impart knowledge to our AMOX members in sonography through webinars, CMEs, workshops, and live demonstration in the conferences. I think Dr. Sujit Konkar is the right person to do this duty on behalf of AMOX. With the galaxy of speakers like Dr. Sujit Konkar, Dr. Aniruddha Kulkarni, and stalwart in this field, Dr. TLN Praveen sir, who is a hardcore teacher in this field of sonography. I think this webinar is a great event. About Dr. TLN Praveen sir, he is really a hardcore teacher. And just, I want to tell one thing specific. Well, at that time, I think sir, remember or not, TrueJet aeroplanes were failed and they were quite irregular. And sir wished to come to Aurangabad for live demonstration. Sir, what to do? Sir told, no, Pardesi, do train. Train is definite, late but definite. I will come by train. And he came by train and he attended our conferences and minimum 3 hours, more than 3 hours, he gave us live demonstration sessions. So thank you, sir. We still remember that memories. I don't want to miss I don't want to in between you and the scientific content. I wish every success to this webinar. Thank you. Thank you so much. Thank you.
I welcome our second guest of honor, Dr. Kiran Karkoti, sir. He is a vice president of AMOX.
Okay, that's okay. Ma'am, we'll get on. Thank you so much. Thank you. You can stop sharing. Thank you so much. Well, today's guest of honor, Dr. Madhuri, a close friend of mine for the last 10-15 odd years. Dr. Madhuri, as you rightly said, AMOX is a part of Foxy, and I would really appreciate from AMOX platform the efforts that Foxy is taking, especially this year in the form of Dhira and Meda. And I'm sure when Rishikesh takes over, you would be there to guide all of us also and take AMOX as well as Foxy forward. So thank you so much for that gesture. And I really appreciate your the last quote that you quoted about Nelson Mandela, that learning is a continuous process. So today also, just as we are logged into the ultrasonography webinar, about 2 hours back, I was logged into another IUSOG program, which was organized by Thane OBGY Society. So then again, that's a big learning process. And as you rightly said, that ultrasonography is the third eye of obstetrician, and apart from obstetrics, gynecological sonography also is going to take further stand. So congratulations to Sujit, who is the organizing chairperson of today's webinar, and thank you, Dr. Anjali Vare and Aurangabad OBGY Society. Last but not the least, really appreciate the presence of Dr. Praveen, who and thank you, Sujit, for including him, because although this is a AMOGS webinar, thank you for associating a person from Hyderabad into our platform. So, you know, AMOGS is crossing boundaries, and that is what is our intention. So thank you so much, and wish you and everyone all the best. Dr. Praveen, I take this opportunity whenever I would be in some position, you will be there in the AMOGS conferences. That much I can assure you for now. Thank you so much. Please get on.
Thank you so much, sir. I welcome our chairperson of today's session, Dr. Anjali Vare ma'am and Dr. Vaishali Surashe ma'am. Dr. Anjali Vare ma'am, she has done her MD from Government Medical College, Aurangabad. She is present president of Aurangabad OBGY Society, consultant at Vare Hospital, practicing since 27 years, conducting adolescent health camp in the school and colleges. She has worked in obstetric HDU. Welcome, ma'am. Dr. Vaishali Gaikwad, ma'am, she has done her MBBS DGO DNB at JJ Hospital, ICOG fellowship in IVF, Foxy USG fellowship. She worked at Vadia and Seven Hill Hospital, Mumbai. Worked at Medical College, Derwan as an infertility consultant. She's practicing since 14 years at Mediart Hospital, Garkheda, and honorary secretary of Aurangabad OBGY Society. Welcome, ma'am. I request Dr. Anjali Vare ma'am to introduce our first speaker, Dr. Sujit Konkar, and the first webinar.
Good evening,
Anjali
respected
Vare,
Dr. Pardesi, sir. Yeah, can you hear me, Swati? Hello?
Yes, we can hear you.
Hello, Swati?
We can hear you.
Yeah, good evening, respected Dr. Pardesi, sir, Dr. Patel, madam, Dr. Kiran Kurtakoti, sir, Dr. Praveen, sir, Dr. Aniruddha Kulkarni, Dr. Sujit Konkar, who is the chairperson of fetal medicine, and dear friends. Thanks, Dr. Sujit, for giving me this honor to be chairperson of this CME. I am very happy to introduce Dr. Sujit Konkar, who will be talking on basic pelvic ultrasound. He is a dedicated sonologist, and our Aurangabad Society is very lucky to have him with us along with his training center, and he is always ready to answer our queries in sonography. He has done his MBBS and MD from Government Medical College, Aurangabad, and taken basic USG training at Dr. Bimal Sahani's Sonoscan Center. He is FMF certified for NT-scan and PE screening and Doppler ultrasound and fetal abnormalities. He is secretary of Society of Fetal Medicine, Marathwada chapter. His Shri Hospital is Foxy approved USG training center, and he is interested in advanced fetal ultrasound, and he is the chairperson of Fetal Medicine Committee, AMOGS. He will be talking on basic pelvic ultrasound. Over to you, Sujit.
Okay. Thank you for nice introduction, ma'am. I'm going to share my screen now. At the outset, I'd like to thank AMOGS, respected Rajendra Singh Pardesi sir, for giving me this opportunity. The topic is basics of pelvic ultrasound. Here, the basics of pelvic ultrasound methodology, normal features, and very common abnormalities will be discussed. Most of the contents are taken from basic ESOP training videos. So what are the objectives? Objectives of the talks are to familiarize with methodology of imaging the pelvis via transabdominal and transvaginal scanning, to recognize normal pelvic anatomy on ultrasound, and to provide an outline for recognition of abnormal anatomy in pelvis. So before going to scan imaging, history taking is very, very important. So one should know the symptoms, patient symptoms, day and length of cycle, various findings from clinical examination, and past history of any pelvic surgery or any other surgery. There is a specific timeline for looking at the variety of abnormalities when you are doing pelvic scan. If the patient is symptomatic, then scanning can be done any day of cycle. But if you are suspecting uterine polyps, call the patient on day 10 or 12. For uterine malformations, luteal field is far better for recognition, and you are suspecting Senechiae, and call the patient in postmenstrual period. Before going to imaging, we must know the normal female pelvic anatomy. From anterior to posterior, anterior, this is the pubic symphysis, then comes the bladder, then this is the vagina, cervix and uterus, posterior to it is the rectum, and this is the lumbosacral spine. So this alignment should be remembered when you are scanning the pelvis. So there is no consensus regarding which method should be tried, transabdominal or transvaginal, but it is a good practice to go first transabdominal way to have an overview of the pelvis, and then go transvaginally to look at the detailed anatomy of the pelvic structures. These are the differences between transabdominal and transvaginal probes. The probe frequency is much higher in transvaginal scanning. So resolution is very good, but penetration is limited. The scanning field is narrow in transvaginal scanning, which is wide in transabdominal probes. So transabdominal scanning is very much useful in visualization of large masses and mid-pose uterus, while transvaginal scanning is very much useful in obese patients which are having very high BMI or they are having retroverted uterus. Bladder should be optimally full in cases of when you are going for a transabdominal scanning. It should be empty when you are going for transvaginal scan. What are the preliminaries to transabdominal scanning? So the bladder should be optimally full. Optimal full means the dome of bladder should be at the level of fundus. The full bladder provides acoustic window for scanning, and it displaces bowel loops and improves the image quality. Now, orientation is very important when you are going for transabdominal scanning. See the probe, how it is kept on the pubic area. It is kept in the longitudinal manner with the probe marker at the cephalic end, at this end. So we get this conventional image. This is the anterior part, this is the cephalad, and this is the caudal part. And in transverse, when you go transverse, move the probe anti-clockwise so that the marker faces towards right of the patient, like shown in this photograph, and you get this type of image. This is the anterior part, this is the right part of the patient, this is the left of the patient. So on a transverse scan, patient's right side is shown to the left of screen, like this way. So this is how it is done. This is the sagittal view of the uterus, then go right slightly parasagittally, go for right ovary, then go to left ovary, then make it anti-clockwise, then go from cervix to fundus, scan whole uterus, and again you can go to the adnexa for visualization of ovaries. Now coming to transvaginal scan. Before going to imaging, you must know about the probe. There are three parts of probe. This is the handle. There is slight notch on this. This is called as probe marker, and this is the part which is called as footprint or scan head. The probe should be covered either with condom or digit of gloves, obviously for hygienic reasons. Some gel should be put into the cover because the air should not be trapped inside, and some gel should be put on the tip of probe to facilitate easy insertion. These are the important tips to optimizing the image. There are four important tips: depth, magnification, focus, and gain. You should initially use a high depth, then magnify the region of interest. There are various ways for that. You can decrease the depth, decrease the scan angle, or you can use the zoom function. You can adjust the focal point to region of interest, then adjust the gain to get a good image. It is mandatory to wear gloves when you are doing transvaginal scan. Probe marker should be at 12 o'clock position, and gently point transducer slightly towards rectum so that there should not be pressure on urethra, which can be painful for the patient. And with the marker oriented upwards, gently move the probe up and down and from side to side. Here you get this type of image. So this is the anterior part, this is the posterior part. This is the urethra and bladder. This is the anterior wall of vagina. This is the posterior wall of vagina. And posteriorly there is rectum. So at this point, you may get this thing. This is not very common, but the point which I want to stress here that you should not jump directly on visualization of cervix and uterus. Give some time to see any pathology in the vagina. Now coming to methodology, when probe is in the midline longitudinal way with probe marker at 12 local position, you get this conventional image. This is the anterior part, this is footprint anterior part, this is the right side of patient, this is the left side of patient. And you get this nice sagittal view of the uterus. So for scanning ovaries, keep the probe in the same position and scan from side to side. You get the transverse section of ovaries when in this position, which are anterior to the iliac vessels. Then coming to transverse scan, they turn the transducer to anticlockwise so that the marker faces to right of the patient. Then move probe upwards and downwards from side to side in this direction. See, the probe marker is facing right side of the patient, and you get this type of image on the screen. And this is the right of the patient, this is the left of the patient, and you get ovary on the longitudinal section. This you get the longitudinal section of ovaries. So this is the sagittal view of the uterus. Keeping probe longitudinal, you go to the right adnexus, see the transverse section of ovary. You go to left transverse section of left ovary, make anticlockwise, go from cervix to fundus to see any pathology, then go to the both adnexa. Here we get the longitudinal section of ovaries in transverse section. Ultrasonographic pelvis doesn't end with visualization of uterus and ovaries. It is much more than that. It includes fallopian tubes as well as broad ligaments. Normal fallopian tubes cannot be seen on ultrasonography unless they are surrounded by fluid or they contain fluid. And broad ligament, it doesn't have any discrete anatomy. It appears as an heterogeneous area. So for this, you have to scan the area lateral and medial to the ovaries. And you have to see pouch of Douglas, some amount of fluid in pouch of Douglas in normal in premenopausal woman. Now coming to position of uterus, version and flexion. Version is the angle between long axis of cervix and vagina. Again, we don't measure it. It gives the direction of the internal os, while flexion is the angle between long axis of uterine body with cervix. Again, here we don't measure it. It gives the direction of fundus. In anteverted uterus, the internal os faces forwards towards the bladder like this. And in retroverted uterus, the internal os faces backwards away from the bladder. In antiflex uterus, the fundus faces forwards and the anterior of uterus is concave, while in retroflex uterus, the fundus faces backwards. The anterior of uterus is convex. There is another position of the uterus, which is called as vertical or mid position, which is most difficult to image. Here, the fundus points away from transducer. The sound penetration is very, very poor. So the visualization of structures is very, very difficult. So in this position, you have to put your left hand on the patient abdomen and you can manipulate the uterus for getting a good view. Coming to measurements. Measurements of uterus are done in mid-sagittal section. Length is measured from fundus to external os, like in these three parts, or better to use a trace from external from fundus to external os. Depth is measured by anteroposterior diameter at the widest part, and width is measured at the widest part of the transverse scan. Ovaries are measured in similar way. This is the total length of ovary. This is the anteroposterior widest diameter, and this is the widest diameter in transverse scanning. In normal premenopausal patient, the length of uterus is 7 to 8 centimeters. The AP diameter is 3 to 4 centimeters, and the transverse diameter is 4 to 5 millimeters. These are significantly less in postmenopausal women. The normal ovary is 50 by 30 by 20 millimeter with volume 5 to 7 cc. Transvaginal scanning is not a static thing. It is called dynamic imaging. There are two important signs mentioned here. One is sliding sign, which tests the mobility of structures. You have to move the probe against particular structure, and independent movement of the structure is demonstrated. Here you can see this is the posterior wall of uterus, and these are the bowels. So with the help of a probe, you can move here. You can see the independent movements of bowels and posterior wall of the uterus. This indicates that there are no adhesions here. Another is the splitting sign. It is used to demonstrate different structures in a complex mass. Here the structures move independently of each other. See here, this cyst and this ovary. We don't know whether this is part of one thing or different. So when we keep probe here between these two, this cyst is deflected away. So this confirming that this cyst is not part of this ovary. This is a para-ovarian cyst. Coming to cervix. This is the mid-sighted view of cervix. So for evaluation of cervix, for complete study of cervix, keep the probes longitudinal and go slightly right paracerital, right slightly left paracerital, then move, make the probe transverse, go up and down, and this completes the examination of cervix. So coming to common cervical findings, these are Nabothian cyst, polyps, and malignancy. Nabothian cysts are mucus-filled cysts on surface of cervix. They are caused by squamous epithelium of the ectocervix growing over the columnar epithelium of the endocervix. This tissue growth can block the cervical glands. And ultrasound, it is seen as round structures which are anechoic and avascular. Cervical polyps are sessile or pedunculated, well circumscribed masses within the endocervical canal. They can be hypo or hypoechogenic. Identifying the stalk attaching to the cervical wall will differentiate it from endometrial polyp. And if we put on color, it may show a feeding vessel. Cervical cancer is demonstrated by the heterogeneous mass involving cervix. It may show increased vascularity on color Doppler. Ultrasound can be helpful here in demonstrating or evaluating the size, parametrial invasion, tumor invasion into vagina, tumor invasion into adjacent structures. And if you look at the kidneys, you may find hydronephrosis, which when the ureters are involved. So, how to describe the ultrasounding findings using standardized technology? So this is the consensus statements, how to measure and how to describe various findings. There are various groups forms. For example, when you are describing adnexal masses, you have to go by the IOTA group, that is the International Ovarian Tumor Analysis. Likewise, when you are describing myometrium and uterine masses, you have to go for MUSA group, that is Morphological Uterus Sonographic Assessment. And for endometrial assessment, there is ITA group. So we have to speak language according to this. So coming to endometrium, for endometrium pathology, you have to keep the probe longitudinal and move just slight right paracerital, slight left parietal, then make it transverse and go from lower to fundus of the cervix, fundus of the uterus, where you have got the complete examination of the endometrium. The appearance of endometrium differ between women before and after menopause, and it changed throughout the menstrual cycle. So this is the endometrium shortly after menstruation. This is a single line, just measurable, just seen. This is the endometrium in proliferative phase. It's called as triple line endometrium, which is nicely seen. This is pre-ovulatory endometrium, which is very much increased in size. And this is the endometrium after ovulation, which is called as secretory endometrium, which can give acoustic shadow. How to measure the endometrial thickness? Endometrial thickness is measured in a sagittal section with widest part perpendicular to the midline. It is an outer to outer measurement, and it is very important to remember that you should not include endometrial myometrial junction when measuring endometrial thickness. What if there is fluid or lesion in the endometrial cavity? So when intracavitary fluid is present, measure the thickness of both single layers and add together to give endometrial thickness. And when intracavitary pathology is present, measure total endometrial thickness, include the lesion, except in cases of submucous myomas, where you have to exclude the dimensions of that myoma. It is very important to look at the endometrial myometrial junctions. In the first image, the endometrial myometrial junction is quite regular. In the second image, it is irregular. And in the third image, it is interrupted. Now coming to most common endometrial pathologies, these are polyps, submucous myomas, and endometrial cancer. So these are the variety of ultrasonographic features of endometrial polyp. This is the bright edge. This is because of the interface between this polyp and the inner margin of the uterus. This is hypergynogenic lesion, which is causing breach in the continuity of the endometrium. You may have regular cyst like this, and after putting color Doppler on, you may get feeding vessels. Submucous myoma, these are the solid tumor protruding into the cavity. It is having same echogenicity as myometrium, and color Doppler shows a ring of color surrounding it. Endometrial cancer shows very thickened endometrium, which is having inhomogeneous echogenicity and with very high vascularity. Color score is very, very high. Coming to myometrium, when you are describing myometrium, coming to myometrium, you have to know three important things. One is the homogeneity. It is uniformly homogeneous. Second thing is symmetry. Anterior part and posterior part, they are symmetrical. And third one is the endometrial myometrial junction, which just has been described. Common pathologies are myoma and adenomyosis. Myoma can be submucous, intramural, or subserous. Submucous myomas, they protrude into the endometrial cavity. Intrametrial myomas, they are into the interlace between the myometrial fibers, and subserous myomas, most of them pop out of the serocell layer. So this is the FIGO classification adopted from Munro et al. This is detailed classification, and which depends on the extent of myoma into the submucous region or subserous region. When you are looking at the myoma on imaging, you have to look at the echogenicity, shadowing, and vascularity. So these myomas can be uniform, like this in 3 images, or it can be non-uniform. This is uniform hypoechogenic, this is uniform isoechogenic, and this is uniform hyperechogenic. And this is non-uniform shadowing giving mixed echogenicity. This is non-uniform echogenic mass, and this is non-uniform cystic areas because of cystic degenerations. There can be a variety of shadowing of the myomas. This is linear shadowing, this is fan-shaped shadowing, or there can be total blockade. Vascularity is also 2 types. It can be circumferential, like this, the border of the myoma, or it can be intralesional into the substance of myoma. As all of us know, there are 3 layers of uterus, basically endometrium, myometrium, and serocell layer. So abnormal presence of endometrial tissue within the myometrium, it is called as adenomyosis. There are many ultrasonographic features of adenomyosis, like enlarged uterus. It can be enlarged asymmetrically or globally. There can be fan-shaped shadowing. You can have various myometrial cysts, and there is poorly defined endometrial myometrial junction, as shown in previous slides. This is the asymmetrically enlarged uterus. The anterior part is much more shorter than posterior part. This is globally enlarged uterus. The endometrium is ended here, and this is the widely enlarged uterus in the fundal area. This is fan-shaped shadowing. It is called as sun ray appearance, or more commonly it is called as a rain in forest sign. These are the various myometrial cysts, and this is the poorly defined endometrial myometrial border. Now coming to ovary, last part of it, we are going to have normal ovary function cyst, benign and malignant in a very short period of time. Appearance of normal ovary differs significantly in women before or after menopause, and this appearance changes throughout the menstrual cycle. So how big is a normal ovary in a woman of fertile age? This was a study done in more than 300 women with age between 20 to 39 years who are having spontaneous menstrual cycles. And this imaging was done in early proliferative phase. And in this study, it was shown that the median volume was 7 ml with a range 2 to 17 ml. If you go to literature, the range is given to 1 to 20 ml. So there is a wide range of the volume of the ovary, but instead of volume, the morphology of ovary is very, very important. And coming to antral follicles, various textbooks show that test that the number of antral follicles are 6 to 7. But this study has shown that the number of follicles ranges from 1 to 36 with median value of 11. As all of us know, the Rotterdam criteria for PCOS test that anything more than 12 antral follicles should be labeled as polycystic ovary. But in this study, 60% patients have shown more than 12 follicles. So Rotterdam criteria was under question. This is because the advent of new ultrasonography machines is high resolution. We are getting various more number of follicles. So recently, the number has been updated to 25 follicles for labeling as PCO. Normal ovary in postmenopausal women. This was a study done in 144 asymptomatic postmenopausal women of 45 to 64 years of age. So median was 1:1:2 centimeter with median volume 1 ml, ranging from 0.4 to 4 ml. These are the changes during menstrual cycle. These are the antral follicle immediately after postmenstrual. Then this is the one follicle is enlarged. This is called a dominant follicle with corresponding triple line endometrium in the uterus. And this is the pre-ovulatory follicle, which is about to rupture. You may see cumulus ophorus at the corner, which is corresponding changes in the endometrium. It is highly thickened endometrium. And this is the ovary after rupture of the follicle. This is the corpus luteal cyst having peripheral ectogenicity with corresponding secretory endometrium. Now coming to functional cyst. These are follicular simple cyst. These are the unilocular simple thin walled cyst which are having very less vascularity. Usually they are having less than 8 to 10 centimeter diameter, and as other functional cysts, they disappear of their own after some period of time. Corpus cysts, these are the corpus luteal cysts. These are the blood clots within it. But if you move the probe with this, they can give a jelly-like movements, and if you put color Doppler on, there is no blood flow within these clots. But at the periphery, these corpus luteal cysts show very good blood flow. Now coming to common benign tumors, these are dermoid, endometrioma, and serous cystadenoma, and mucinous cystadenoma. Dermoid cysts, they are very common in childbearing age. Most of the patients, they are asymptomatic. In 20% of cases, they are seen in bilateral ways. They are having varied ultrasonographic appearance, but it is easy to diagnose because these are showing unilocular cysts with complex echoes showing acoustic shadowing. Various ultrasonographic terminologies and signs have been described here, like tip of iceberg sign, dot dash line because of hairs in it, or Rokitansky nodule, which is the hyperechoic component corresponding to mixed hair and sebaceous material. Endometriomas, here these patients present with cyclical pelvic pain and infertility. These are the unilocular fluids filled with low-grade echoes giving ground glass appearance. In many cases, you get echogenic foci at the border, and which increase the likelihood ratio of being endometrioma. Now, cystadenomas can be serous or that can be mucinous. Serous cystadenomas, they are unilocular, they can be multilocular with various septae in between like this. And important to know here is cystadenoma fibromas, which may have papillae even though they are benign, and these papillae show acoustic shadowing. Remember that in adnexal masses, there are 3 lesions which gives acoustic shadowing. These are dermoid, which has been described earlier, papillae of serous cystadenoma, and fibroma. So remember these 3 findings. Then mucinous cystadenoma, this is the unilocular mucinous cystadenoma, giving this echogenic thing, and these are the multiloculated mucinous cystadenoma, which is having variety of echogenic material. The echogenicity is not same, and many times mucinous cystadenomas very, very large. Fibromas are not very common, but they are having specific peculiar ultrasonic finding. These are the well circumcised solid lesion in adnexa giving acoustic shadowing. Now coming to common adnexal or extra-ovarian adnexal pathologies which are benign. First one is hydrosulfings. Normal fallopian tubes, as already described, is not seen on ultrasonography unless it is surrounded by fluid or it contains fluid. If it contains clear fluid, it's called as hydrosulfings. If it contains turbid fluid, it's called as pyosulfings. Or if it contains blood, it is called as hematosulfings. Usually these are saucer-shaped lesions. This is the cross section of inflamed tube, where this is the mucosal area. This is inflamed. This is giving cogwheel appearance. And this is the hydrosulfings in chronic inflammatory state. These mucosal lines, they have become fibrotic, giving a beads on string appearance. The most important sign of hydrosulfings is the incomplete septation as shown in this image. Para-ovarian cysts, these do not have any much clinical significance unless most of the time they are confused with ovarian cyst. The splitting sign already described can be used to differentiate between these two. And peritoneal eccogen cysts, these are the cysts within the layers of tissue planes. These are very irregular. They are having right angles. Many times ovaries is suspended into that, and they are having very labile septa. It is called as flashing cell sign. Now coming to malignant tumors, it can be borderline tumors, invasive tumors, and metastatic tumors. The characteristics of malignant tumors are multilocularity, wall irregularities, papillary projections, other soil components, high color score, ascites, peritoneal implants, and omental cake. So what are the diagnostic methods to discriminate between benign and malignant adnexal pathology? So if you go by IOTA simple rules, they have described some malignant features which are very important, and some benign features of the adnexal mass. So malignant features are irregular solid tumor, presence of ascites, more than 4 papillary projections, irregular multilocular solid tumor, more than 10 centimeter, and highly vascular, that is color 4 is more than color 4 score is 4. Benign features are unilocular cyst, tumor with largest solid component, acoustic shadows, smooth multilocular tumor less than 10 centimeter, and very less vascularity. Color score is just 1. So we call it as a malignant mass if there is more than one malignant feature without any benign features. We call it as a benign if there is one or more benign features without presence of any malignant features, and we call it as inconclusive if there are no features present or both the malignant and benign features apply. So take home message: pelvic ultrasound is very valuable in identifying pelvic structures. It can be done either abdominally or transvaginally, but better to go transvaginally initially to have a good overview of the pelvic structures and go transvaginally to get detailed anatomy of the pelvic structures. It is very important to familiarize with important pelvic anatomy. And when a scanning protocol is followed for pelvic structures, identification of abnormal morphology becomes easy. Thank you. Thank you for being online.
Thank you so much, sir. It was quite knowledgeable talk. And for a budding sonologist like us, which is a rarely discussed topic, basic pelvic USG, it was really helpful for all of us, especially the one who are in the phase of learning USG. Thank you so much. I request Dr. Anjali Vare ma'am and Dr. Vaishali Surase ma'am to give expert opinion on sir's talk.
Sujit, you had told everything in detail. It was a very excellent talk. I think everyone everyone is impressed with your knowledge and all, and you are always best in your society. Thank you. Thank you very much.
Thank you, ma'am.
It was a great talk, sir. A very practical, knowledge-giving talk. Thank you so much for imparting the knowledge to us. Thank you.
Thank you, ma'am. Thank you, both of you. I request Dr. Vaishali Surase ma'am to introduce Dr. Aniruddha Kulkarni sir for the second talk. Dr. Vaishali ma'am.
The second talk for the evening is by Dr. Aniruddha Kulkarni sir. He's a very famous radiologist. Sir is a director and faculty at Scholar MD. He is a professor in radiology. He is the joint secretary of IRIA and past secretary of MSBIRIA. His areas of interest are urogenital, neck, and pediatric ultrasound. He has written over 2 chapters in textbook of radiology and has 23 index publications. He is a reviewer Journal of Radiology. Sir was a national and international faculty in ultrasound conferences. He has an innovative skill developer in ultrasound teaching, and he is a film enthusiast and avid traveler. Welcome, sir, and eager to listen from you. Over to you, sir.
Thank you very much for those kind word of introduction.
Thank you, sir.
At the onset, thank you, Dr. Sujit, Dr. Pardesi, Dr. Anjali Vare. I think during initial phase of my career, one of the first ectopics I could place at Dr. Mrs. Vare's place, and I really enjoyed working with her. So just let me share my screen. I hope my screen is seen and the text is also well placed.
Yes,
For myself, Dr. Anil Kulkarni, I will be speaking on ectopic pregnancy practical approach on ultrasound. No financial disclosures. Cases belongs to my clinic. Referring the physicians are usually the friends in Obstetric Society, Dr. Anjali Vare, Dr. Sujit, Dr. Ashok Bagadia, Dr. Bhartiya, and many others, including Tandalia and Ingolese. Articles are duly acknowledged appropriately during my talk. And special mention Dr. Keelan Praveen, who is my mentor and who is my reference for each and every talk that I prepare. And even for this talk also, last weekend I prepared a talk for Singapore and he was there always to help me for maybe text or the cases. So thank you, sir, always for promoting and encouraging me to do something different. So that's all. Implantation of an embryo at a site which is other than the endometrium is classical pregnancy, out of which I will not be dealing with the clinical presentation, biological markers, but we'll be speaking more on ultrasound classical features, local MTX management, and I will show one demo case for the same. When we say normal intrauterine pregnancy, the gestational sac is located within the uterine cavity with trophoblast not extending beyond the endomyometrial junction. And how do we get the endomyometrial junction? It is, we can see it on 3D recon images, which we can receive on volume probe. So uterine cavity is defined as the virtual space lined by the endometrium, extending from the uterine ostia of the fallopian tubes to the internal os lower down over there. So anything within this is intrauterine. Don't worry about the same. But when we see eccentrically placed gestational sac near the lateral end of the endometrial cavity, don't worry, don't label them as a cornual pregnancy, angular pregnancy, or the interstitial pregnancy. And Dr. T.L. Praveen will definitely let you know how you have to go about those pregnancies. Yeah, I will describe the technique in a little bit of detail. We need to go with transabdominal scan first because we can assess the hemoperitoneum and the collection better way. We can extend our examination to Morrison's pouch and lateral pelvic gutters. We need to use transmanual transducers with a high frequency so that we can do a spatial tissue characterization in a far better fashion. And we used to consider that the volume probe or the 3D acquisition multi-slab technique as a fancy tool. But nowadays we have realized that it gives so much of additional information and level of confidence that it has become a mandatory in the last 3 to 5 years. Bimanual examination is an excellent maneuver and need to be advocated in most of the cases. Just see to it that the patient is not having rupture ectopic where you are causing excruciating pain in those females. Try to elicit always carefully the tenderness, and as tenderness elicitation has to be the last one to see during your examination. And whenever you are applying color Doppler or a power Doppler, do not exclusively rely on the signs of color Doppler because they are always and always fuzzy or clinical. The practical way of classifying it as usual or unusual ectopic or a tubal or a non-tubal ectopic, out of which the non-tubal ectopic will be dealt in great detail by Dr. T.L. Praveen, sir, depending upon the implantation, whether it's a fundal implantation or a low implantation. In terms of some incidents of tubal ectopic pregnancy, we know that tubal ectopic are the commonest to the ranging of 80% or so, which is followed by the ischemic one, which is followed by the infundibular one. But we are more worried about the interstitial one and the rupture ectopic one. But looking at this picture, we need to understand all the radiological signs of adnexal ectopic will be related to number one, lateral margin of the uterus, the tube over there, and the ovarian component below. And the first and foremost thing that an imaging guy should do is that whatever lesion seen in the adnexa need to be separated from the ovary on that side. So what are the ultrasound features? In case of a tubal ectopic pregnancy, the uterus can be normal, it can be enlarged. The cavity will show signs of a pseudosac, which has got a very variable spectrum ranging from a minimal fluid collection, echogenic pseudomass, echogenic collection like a clot, to a double decidual cast like a feature within the cavity. There can be extrauterine and non-ovarian mass, which needs to be demonstrated bimanually separate from the ovarian region. There can be a periodic collection along with the debris echo and the clots, and there can be increased vascularity, which is of a very bizarre kind of a nature. And whenever you find that the ring of fire sign, adnexal tenderness, and the beta HCG in absence of a sufficient evidence of on ultrasound to be ectopic pregnancy, don't rely on ring of fire sign. Now just look at these two patients, these two different patients. Here you can see that there is a minimal fluid over there, but this is nothing but a what you can say a created margin of a collapsed corpus luteal system. And whenever such lesion along with ring of fire sign, method of the power Doppler is present within the ovary, you are likely to consider it depending upon the beta HCG titer as an ovarian pregnancy. But my own experience, and I think most of the people will agree that ovarian pregnancy per se itself is a quite rare diagnosis. Unless or until you are quite sure in terms of ovarian pregnancy, you should not report ovarian pregnancy as a primary diagnosis. In terms of ectopic pregnancy, looking at the signs, we are always looking at the adnexa. And as I stated, my first responsibility has to be to see the lesions separately from the uterus as well as separately from the ovary. So what are the ultrasound findings in case of a tubal pregnancy? Sorry, or interstitial pregnancy? A live extrauterine gestation with the adnexal mass or a tubal ring sign or a ring of fire sign with pelvic hemorrhage. If you are fortunate enough to demonstrate anything, something like that, then definitely it is going to be tubal pregnancy. In case of interstitial pregnancy, eccentrically located gestational sac with a gestational sac surrounded by a thin mantle of a myometrium, which is less than 5 millimeter, with a classical demonstration of interstitial line sign or interstitial tube sign, will be fortunate enough to say that it's an interstitial pregnancy. Now, pseudosac appearances within the uterine environment could be a presence of a what you can say a central minimal fluid or over irregular empty sac-like feature with a lot of heterogeneity. On many instances, if there are hemorrhagic clots within the cavity, they mimic like a yolk sac or the embryo. But the moment you can demonstrate a good decidual reaction or what is called the intradecidual sac sign, which is placed over the central ecogenic interface within the decidual reaction, then you are quite sure that probably it's the initial event of an intrauterine pregnancy. And always, if the current Doppler, then absence of a tropoplastic pattern will be seen in case of a pseudosac appearances. Now here you can appreciate a classical pseudosac appearance where there is ecogenic collection within the cavity. The other features could be a decidual reaction like a feature or a minimum fluid within the sac, or a double decidual cast like a feature where there is an inner margins is not a hyperechoic, which is also seen in case of a double decidual sac. So these are the various patterns of pseudosac, which we also will be dealing with the other signs of tubal pregnancy. In terms of signs and the level of confidence with which we can label it to be a tubal pregnancy would be empty uterine sac. As the complexity of structure in the adnexa goes on increasing, your sensitivity goes on increasing. At the same time, your specificity and positive predictivity value goes on increasing. What does it mean? When there is a adnexal mass along with free fluid, along with bizarre vascularity in the adnexa, your specificity as well as positive predictive value is very, very high. Now here you can see there is one more technique which is now has been advocated because of high frequency transducer, that is called the tracking of tubo-ovarian ligament. Now, as here you can appreciate that it's the uterine cavity, and what I am practically doing is that during my sagittal scan, looking at the fundus, I am just trying to go and look at the tubo-ovarian ligament, which is at the lateral cornual end and starting from there. But I can now see a hyperechoic double decidual ring kind of a sign, which is in the proximal proximity of a lateral cornual end, which is nothing but what is called the ectopic pregnancy, the tubal nature. The next one is what is called a tubal ring sign, where you can see the ovary separately, and I can see a tubal ring sign over there. At the same time, during my bimanual examination, I can separate the tubal ring not only from the uterus as well as from the right ovary on this side. So tubal ring sign, whenever these demonstrated, need to be separated from the uterus as well as the ovary. lot of literature states the tubal ectopic, the classical feature is what is called the bagel sign, which we usually see in our breakfast menu in a star heartbeat, and this is how it looks like on transvaginal ultrasound. So in case of a bagel sign in this patient, you can see this is a classical bagel sign. At the same time, I can discriminate the bagel sign from the right ovary along with small amount of fluid collection adjacent to it. The uterus will show what is double decidual kind of a reaction within the cavity, but the inner margin is not classical hyperechoic, which is seen in case of a normal intrauterine sign. You can see a bagel sign on this side in this patient. Now, this is again a bagel sign. Even can be demonstrated on transabdominal scan. The uterus is empty, and on the left side, you can see a double decidual sac-like feature on color Doppler. Now I can demonstrate there is a feature of a ring of fire sign, but all the feature of adnexal tubal ectopic pregnancy are demonstrated in this patient. So I am going to give significance to this ring of fire sign because along with ring of fire sign, I can demonstrate the bagel sign as well as the remaining uterine cavity and the pelvic areas also shows feature of a tubal pregnancy. Now, what is called a blob sign? So in case of whenever you say a blob sign where there is a hyperechoic rim-like lesion adjunct to the right ovary or a left ovary, but again on bimanual examination, you should be able to say that this blob I can separate from the right or the left ovary on that side. So again, separating the blob sign away from the respective ovary is mandatory to say that it's a tubal pregnancy. So bimanual examination will help you to slide ovary over maybe the tubal ring sign, maybe the blob sign or the bagel sign on that side, which will separate the lesion with the ring of fire sign away from the ovary on that side or the lateral wall of the uterus. Now, what is the finding in this patient? You can see that I can demonstrate the tubal thickening over there, but on the same time, I can see the corpus luteum over there, but I can see the hyperechoic rim-like shadow. I can see the embryonal disc-like lesion over there, which is away and distinctly separate from the thickened tube, and it was nothing but a ruptured tubal pregnancy. There is a various features which have been demonstrated in cases of a tubal pregnancy, out of which most of the times the thickened tube only will be seen when it will be containing fluid within the cavity and outside the cavity, which is nicely seen in this patient. Here you can see that there is a lot of tubal thickening. There is an adjoining fluid collection over there, and I can see some amount of a cobra head appearance at the femoral end, which shows that it is nothing but a tubal abortion over there. Now, in terms of a tubal abortion in this patient, I can see that the uterine cavity is containing minimal amount of fluid collection. I can demonstrate the anterior lower segment scar area over there. But during the senior loop, you can identify that here you can see that the classical hematosalpinx, there is a pelvic collection adjoining to that area on that side. The ovary can be made separate from that side. Depending upon the beta HCG titer and clinical presentation of ectopic pregnancy in this individual, I would say that I am dealing with tubal abortion. Now, on many instances, there can be a chronic tubal ectopic pregnancy where you will see a tubal, the corpus luteal lesion on that side. You will see an empty uterine cavity over there. And you can see this here, you can see a inverted U and what you can say a semi-lunar lesion, which is within the tubal region over there, which is mimicking that of a bizarre chronic mass in the adnexa. With the history and supportive evidence of beta HCG and bleeding PV, I would say that I am dealing with chronic ectopic pregnancy. So on many instances, on acute setting or a chronic setting, there can be a tubo-ovarian mass, which is inhomogeneous nature. That can be because of tubal abortion or a chronic tubal ectopic pregnancy. Now here you can see there's a left ovary, and this is which is encompassed by a tubal mass over there, which was nothing but a hematosalpinx. Now here you can appreciate the same. This is a hematosalpinx and the ovary, which is medial to the same, and it was on color Doppler. You can see that there is a bizarre kind of vascularity involving the left adnexa over there. In case of a chronic ectopic, which shows classical TO mass with the hematosalpinx. Here you can see there is a classical TO mass. The ovarian component is encompassed by the tubal component which is showing hematosalpinx and chronic thickening. There is an adjoining area of a lot of inflammation involved in the same, and there is no much intraperitoneal collection involved in this patient. From the management point of view, there are two ways in which we can treat this patient, that is intrasac mitral installation, which is ectopic ablation technique, or systemic MTX, or combination of the both things. Whenever the sac size is less than 3.5 centimeter, the beta HCG is less than 5,000. With the hemodynamically stable patient, we can always use this maneuver in cases of non-tubal pregnancy as well as in case of a tubal pregnancy as per the recent literature. The beta resolution can take up to 74 days. That too, whenever you are using intrasac MTX, the initial values of beta HCG will be higher, and the resolution time taken whenever you are using intrasac MTX is going to be more. And traditionally, it says that it takes more than 19 to 29 days as compared to systemic 2 or multiple dose therapy of methotrexate. In case of a heterotypic pregnancy, which initially used to say as an uncommon, now it's a rising trend. Initially, it was 1 to 7,000. Now it has become almost to 1 to 3,000. And we need to be aware that one of the good clue is that whenever you are demonstrating well-defined corpus luteal lesion on either side or on the same side, two corpus luteal lesion in the patients, then definitely if the uterine environment supports, then you should consider heterotypic pregnancy. Now, this is a classical heterotypic pregnancy where you can see the intrauterine pregnancy as well as extrauterine pregnancy. In case of heterotypic, then probably it says that the transvaginal intrasac KCL will be more useful, but the literature of recent times says that MTX local activity may not be what you can say sufficiently high enough to cause the systemic circulation impact over the intrauterine sac as well. So now there have been trial which is going on, which says that you can use KCL as well as MTX. In terms of uterine pregnancy, I will not speak about rest of the same, but just mention about the interstitial one. We know that the interstitial portion of tube is 1 to 2 centimeter. It is around 7 millimeter wide, which is encircled by the gradually thinned out myometrium. Now, the pregnancies at the uterotubal junction are interstitial or angular or the cornual. And few scholars, they say that we should abandon the term angular or the cornual because on many instances, the angular pregnancy has a normal intrauterine course. So interstitial pregnancy needs a lot of attention because it has got a poor prognosis and needs to be treated urgently. So what is interstitial pregnancy? The implantation occurs outside the endomyometrial junction, causing bridging of the same, where the blastocyst is implanted in interstitial portion of the fallopian tube. So you can make out, so this is classically what is called as a angular pregnancy, which eventually will turn into the normal eccentrically placed intrauterine pregnancy. So thin line connecting the endometrial cavity to the tube is what is called the interstitial line sign or interstitial tube sign. To demonstrate the interstitial line or the interstitial tube, it is the volume analysis by using 3D probe along with multi-slice technique has to be used in each and every patient. What are the features of interstitial ectopic pregnancy? You will get an empty uterine sac. The gestational sac is identified separately away from the lateral edge of the uterine cavity by at least 1 centimeter. There is a breach of endomyometrial junction halo, which is seen as a hypoechoic region adjoining to the endometrial cavity. There is a thin myometrium mantle, which is surrounding the gestational sac, which is closer to 5 millimeter. And there is what is called the presence of interstitial line sign or interstitial tube sign, which may not be demonstrated on grayscale ultrasound, but it's a 3D coronal reconstruction which will demonstrate the same, in which the tube and the thinning myometrium covering of 5 millimeter can be seen very, very beautifully. Now here you can see this is endometrium, this is the interstitial line, and this is what I am referring to as the interstitial tube sign. Now here you can see on this view of a coronal endometrial cavity, I can demonstrate nicely. The endomyometrial junction zone, I can demonstrate very nicely. And this is what is called the interstitial line sign. And I can see that there is a classical interstitial pregnancy over there, along with very thinning of myometrium adjoining to the same. Here also you can appreciate the same, where there is a endometrial, this is uterine cavity, and the gestational sac is distinctly away from the endometrial cavity as well as the lateral end of the endometrium. The treatment option for them is usually systemic methotrexate, 50 milligram single or multiple on 1 or 4, or multiple doses 1, 4, 5, 7. Local MTX, ultrasound guided intrasac restriction, is also useful, where you can either use 25 milligram or 50 milligram. On many instances, will be advised laparoscopy or a laparotomy. Just to mention regarding angular pregnancy and a cornual pregnancy, angular one is an implantation of blastocyst medial to uterotubal junction at the lateral angle, which may eventually turn into a normal course of intrauterine pregnancy. And the term cornual pregnancy should be always be used when you are using it in reference to anomalous uterus. Hence, angular pregnancy and cornual pregnancy should not be labeled as ectopic pregnancy at all. Now, this is how this is a classical angular pregnancy looks like. You can see that this endometrial cavity is well defined. I can demonstrate gestational sac over there. Here, very nicely and beautifully seen. And as soon as I use the coronal reconstruction, I can demonstrate that it is in relation with the tubo-uterine junction, but it is distinctly not away from the endomyometrial junction. So bridging of endomyometrial junction is absent. So I am not going to call it as an interstitial pregnancy. It can be also seen on a coronal reconstruction view. Now, in era of a non-tubal MTX, what you can say that the ultrasound guided local MTX has a big role to play. You can follow up it with beta ECG titer and watch for presence or absence of the pelvic collection in those patients. How does MTS affects? It's a folic acid antagonist and antimetabolite. Methotrexate stops the growth of a rapidly developing cells, that is embryo and a chorionic tissue. It primarily affects the trophoblast production in case of a gonadotropins. Less than normal progressive increase in HCG is responsible because of MTX. It also causes destabilization at the level of implantation size, and it causes less support of production of progesterone. So all this will lead to the ablation of ectopic pregnancy of tubal or non-tubal region. So in terms of a case selection, what is mandatory is that you should be able to demonstrate a nice tiny gestational sac which is separate from the ovary on that side with the size less than 3.5 centimeter. On many instances, you can see that it's away from the uterine horn over there. There is no pelvic collection over there. On many instances, you can see a beautiful extrauterine pregnancy of a tubal nature, which is very small, with having hemodynamically stable condition. So either you can give a single in systemic variety, what you can do, single dose, 2 dose, or multiple dose. If there is a decrease in the beta HCG titer, why more than 50%, 15% after the first injection, there is no need of giving second injection. But if there is no drop of beta HCG by 15%, you can additionally give the second dose, which is intramuscular again. Again, if there is a plateau or increase, then definitely you should consider it as a continuation of a tubal pregnancy or extrauterine pregnancy, for which it should be treated depending upon the merits and the hemodynamical conditions. In terms of procedure, you should use transvaginal route. You can use transabdominal if it is more than 10%, 10 centimeters from the vaginal orifices. Well-informed consent of the couple is mandatory. You should signify the follow-up ultrasounds as well as beta HCG level monitoring. You need to tell them that in case of failure, surgical intervention is mandatory. You should also tell about the systemic manifestation of MTX adverse reaction. You should also explain regarding future fertility. You should also explain regarding the limitation and what is meant by the clearance. What are the absolute contraindication? Intrauterine pregnancy, again, on many instances, if there is a hepatic dysfunction, there are renal dysfunction, if there is a rupture ectopic, it's absolute contraindication. Many people, they say that the initial beta HCG, if it is high, or the ectopic gestation is more than 4 centimeters. It's a relative contraindication, but there are few trials nowadays going on at many centers where you can still use it up to 10,000 international units or sac closer to 5 centimeters, even with embryonal disc with pulsation. We should also know that side effects of the drugs at the same time, what is predictor of failure of MTX treatment, whether systemic or local. If there is adnexal fetal cardiac activity, size and volume of gestational sac which is more than 4 centimeters, initial high concentration of beta HCG, again the chances of failure of MTX treatment is going to be high. What is effective result? As I stated, a decrease in beta HCG by more than 15% between day 4 and day 7 after local MTX installation or after single or 2 dose or multiple doses, then we can say that it's a successful medical management or a local management. The criteria of successful management denotes that the patient is stable, there is no intraperitoneal collection, and the beta HCG titers are less. Just to mention how to identify the lower segment scar, we can see there is an echo dropout area or a hyperechoic area which is going towards the internal os, or there can be niche involving the anterior lower segment which is also dipping towards the bladder area. And this is classically what is anterior lower segment ectopic pregnancy involving entire level of a scar over there. Now, this is the instrumentation that I usually use. There is a handle which goes along with a guide which is there, which is adopted over the transference transducer, and this is the needle that I use. So in case of this needle, there is a throwaway of 1.5 centimeters beyond the tip over there. So the route can be transabdominal or transvaginal. At the same time, we need to introduce the MTX of 25 milligram or 50 milligram into the sac area. Let us take one example. Now, this is classical lower segment scar implanted pregnancy where there is a classical scar almost replacing the anterior lower segment. And what we have done here, I have put in a needle through a transvaginal route. At the same time, little bit of nibbling helps me to distract the yolk sac, which is nicely seen over there. After distracting the same, I have introduced after the nibbling methotrexate within the gestational sac over there, and then you can see that the gestational sac is being replaced by the MTX volume over there. The preferred route, as I stated, is the transvaginal one. We have seen that the beta HCG on day 4 and day 7, it decreases by 15%, then our achievement in terms of clearance is received. If there is a plateau or increase after above measures also, that is giving additional intramuscular MTX also, should be treated as a persistent ectopic pregnancy, and surgical therapy should be advocated in this. There is one more treatment which can also be used in case of a cesarean scar pregnancy, and thank you Dr. Prashant Singole for the same, where what we can do is that we can introduce a Foley's catheter into the cervical region, and now here you can see this is a cervical this is a cesarean scar pregnancy where you can see there's a little bit of tenting over there into the scar area, and here you can identify the cesarean scar pregnancy where it is being lifted into the scar area over there. So after putting this silicone balloon Foley's catheter within this zone, it should be kept for either 24 to 48 hours, and then you can see that there is a complete destruction and lysis and necrosis of this zone, which leads to a little bit of bleeding PV, which later on can be described, they can disappear very well. There are few articles which I need to mention for the same, that is ultrasound guided injection of MTX versus laparoscopic scalping in case of ectopic pregnancy. The literature have stated that the systemic MTX as well as local MTX along with systemic MTX is always better than the laparoscopic salpingectomy in case of ectopic pregnancy. But the comparative statement between local MTX or only systemic MTX is still to be documented to a greater level. So we need to understand that there are certain things which needs to be again done on a meta-analysis to prove that the local MTX is better than the only systemic MTX, because local MTX on many instances takes 90 to 29 days to give effective clearance as far as the beta HCG is concerned in comparison with the systemic MTX alone. So we must read the article which states the ectopic pregnancy current management guideline. The guideline says that PCL and aspiration should be used in case of ectopic pregnancy. The consensus law up till now is that in case of a tubal or a non-tubal pregnancy, having fetal pulsation should be avoided for intrasac MTX or the multiple dose MTX. All the patients of non-tubal or tubal which are hemodynamically stable are no more contraindicated for MTX. So after introducing MTX, the beta HCG level between day 4 and day 7, it decreases by 15%, followed by beta HCG weekly till reaches to non-pregnant stage. So follow-up on ultrasound and beta HCG titer is mandatory. If it doesn't occur, then we need to go ahead for additional systemic intramuscular MTX, 50 milligrams per square meter body surface area, followed by weekly, so that it reaches to a non-pregnant stage. And if it does not occur at all, then you should consider it to be a persistent ectopic pregnancy and treat it accordingly. So, in short, tubal pregnancies can be diagnosed confidently if we go stepwise fashion. High index of suspicion is required in diagnosing this, looking at the cavity and adnexa. Don't rely on the ring of fire sign isolated in absence of other sign. Majority can be treated surgically if they are hemodynamically unstable, but hemodynamically stable, definitely systemic MTX is of a popular choice, and even local MTX has a role to play. Local MTX methotrexate is useful in selective cases. In case of heterotypic pregnancy, to preserve the intrauterine pregnancy, aspiration with local KCL has been advocated very well. So thank you very much for your patient listening. And once again, thank you, Dr. TLN Praveen, for always guiding me for preparing something good and innovative, which is of day-to-day significance. Thank you. Appreciated all for joining online. Thank you.
Thank you so much, sir. Thank you, Anirudh, sir. That was a quite educative lecture, and the new things which we have learned today about the management of the tubal ectopics. I request our chairpersons to give expert opinion and remarks on this topic.
Thanks, Dr. Anirudh. It was a great talk. And he is one of the best sonologists in Aurangabad. And he is the one who always keeps clinical track and always calls the clinician and asks about the patient. He is the one of them. And still today, whenever I have got doubt, I send the patient to him and just ask, you just tell me whether it is ectopic or not. And if he says like that, I am very happy. And he's very confident, and I am also confident about him. And he has told every minute detail about diagnosis of tubal ectopic. And also he has shown a very nice USG guided Foley's catheter used in scar pregnancy and injection methotrexate locally. Thank you. Thank you very much. It was a very nice talk.
Thank you, ma'am. I request Dr. Anjali Vare, ma'am, to introduce our second speaker, that is Dr. Praveen, sir, for the third and final talk.
I am very honored to introduce Dr. TLN Praveen, sir. He is practicing fetal medicine since last 35 years. He has got passion looking at the fetus and performing invasive procedures, and he is having teaching and training center, that is postdoctoral students, and he has got a hobby of running and hiking. He has got award of Certificate of Excellence for first coronary angioplasty.
I think, madam, it's enough. We will go to the talk because it's already.
I am very honored to introduce you, sir.
Thank you, ma'am.
Thank you very much.
Thank you very much. Can I share the screen?
Yes, sir.
Good evening, everybody. I know it's too late. It's almost 9:30 and we are talking about ectopic pregnancies. But before I start, I would really thank Dr. Sujit and Amox for giving me this opportunity to be with you all today, a webinar, and talking to you about non-tubal ectopic pregnancies. Anirudh has taken us through a lot about the ectopic pregnancy. Just to reiterate, implantation of an embryo is what we define it as an ectopic pregnancy when it is implanted other than the endometrium site. Now, we need to have a holistic approach as far as the ectopic pregnancy is concerned. So when we talk about the holistic approach, we have the clinical presentation, biochemical parameters, ultrasound features, and management strategies. Now, I will just briefly take you to the clinical presentations and tell you regarding the biochemical parameters which we are going to use, and then take you through the various ultrasound features which are pertinent to non-tubal ectopic pregnancies. Now, when normally we do get, as it has been already stated, that once they, in the present generation, once they miss their period, they get a urine test done. Once the urine test comes positive, then they come to us, and that is the time when, if they clinically present with the clinical triad such as the amenorrhea, lower abdominal pain, as well as spotting or vaginal bleeding, that is when you get worried. And when you do a transvaginal examination, if you don't find the sac within the uterine cavity, you're much more worried. This sort of a clinical scenario, as well as unable to detect the gestational sac within the uterine cavity, occurs quite often in early pregnancy. That is where it is too early to be able to detect the gestational sac within the uterine cavity, and the bleeding or the lower abdominal pain is basically because of implantation bleed. Then comes the failing intrauterine pregnancy or early pregnancy failure features, wherein we can have sometimes that the clinical presentation will be lower abdominal pain as well as spotting. And the one which is really troublesome is the PUL as well as the failing PUL, that is pregnancy of unknown location. Of course, the most important thing that we are all worried about is the dreaded extrauterine pregnancies. Now, the normal intrauterine pregnancy is the one where the gestation sac is implanted in the endometrium, and it should never breach the endomyometrial junction. That is the definition of an ectopic pregnancy. If the gestational sac is implanted within the endometrium without the trophoblastic tissue, you can see this ridge-like structure here. If it is not breaching the endomyometrial junction, we are confident that it is an intrauterine pregnancy. And as Anirudh has already told us, that it's an eccentrically located normal intrauterine pregnancy. This is one thing which we have to be very, very careful and very sure about, because eccentrically located normal intrauterine pregnancy progresses to term. Whereas if it is an ectopic pregnancy where there is a breach in the endomyometrial junction, these are the things that we label them as ectopic and manage them as ectopics. So with this, we know the endometrial cavity extends right from the internal os to the cornu. And then whenever they come to us with a positive pregnancy test, there are 5 possibilities that we have to think about. 1, a definite demonstration of a gestational sac, yolk sac, and embryo within the uterine cavity where we know that it's an intrauterine pregnancy. And the other one is a probable intrauterine pregnancy where we have an intrauterine sac-like structure, but then we are not very sure about the yolk sac as well as the embryo, but still we could think in terms of a possible intrauterine pregnancy. Then a different ectopic pregnancy where there is an extrauterine, extra-ovarian, gestational sac plus a yolk sac and the embryo. Remember, this sort of presentation occurs only in 20% of ectopics. The rest of the ectopics are a little complicated, has a bizarre ultrasound features, which we have to be very careful about. So only in 20% of the cases, you do definitely see an extrauterine gestational sac, fetal node, and the yolk sac. Now, probable ectopic pregnancies are whenever you find an inhomogeneous adnexal mass, such as the blob sign, or an extrauterine sac, that is the Weigel sign, then you think in terms of a probable ectopic pregnancy. And the least and the most troublesome thing is the PUL, that is pregnancy of unknown location, where you can either demonstrate the gestational sac within the uterus or outside the uterus, that is the ectopic pregnancy. And that is where we need to, this is an entirely different aspect which we have to deal separately. I'm not going to touch that one in this talk. Now, how do you define ectopic pregnancy? How do you classify them? As we have already defined the ectopic pregnancy, classification can be, you can classify them as usual, unusual ectopic pregnancies, or you can call them as tubal, as today we have been doing it, as tubal pregnancy and non-tubal pregnancy. and also the heterotopic pregnancies. Now, when we talk about the non-tubal pregnancies, we can again classify them based on the site of implantation. If the site of implantation is around fundal region, then we need to think in terms of an interstitial pregnancy or the coronal pregnancy. If it is a low implantation, we need to think in terms of cesarean scar pregnancy or the cervical pregnancy. And other than these sites, the non-tubal pregnancies can occur in the ovary. It can be a heterotopic, it can be abdominal, secondary abdominal or abdominal pregnancy, or an intramural pregnancy. These are all the various types that you can come across. Or you can even classify these ectopic pregnancies as extrauterine and uterine ectopic pregnancies. So with this classification, as it has already been stated repeatedly, that the ectopic pregnancies, 95% of them are tubal, whereas all other types of non-tubal ectopic pregnancies are account to only about 5% of the cases. So I'm actually talking to you on a very, very niche aspect, that is only 5% of ectopic pregnancies that we come across in our day-to-day practice. But the problem is that these are the ectopics which will trouble us in our day-to-day practice, where we need to identify them, or else it will be a catastrophe. Now, coming to the ectopic pregnancy management, we have various strategies that are available. One, it could be an expectant management, just sit and watch. The other one is a conservative medical management, that is when you give a systemic methotrexate, or it can be a minimally invasive ultrasound-guided management, wherein we can introduce intrasac methotrexate and ablate the ectopic pregnancy, or it can be a surgical management in the form of laparoscopy or a laparotomy. Remember, one most important thing is that whenever we do manage conservatively these patients, we are minimally with ultrasound, under the ultrasound guidance. It's always interchangeable in the sense you do a ultrasound guided management, and whenever the beta hCG titers don't come down, in that situation we again give a systemic methotrexate. So we complement these two, one with the other, so that we achieve the best results. Now, coming to the non-tubal ectopic pregnancies, which I already have stated to you, let us first start off with the fundal implantation. When we talk about the fundal implantation, a lot has been covered by Dr. Aniruddha, wherein he has talked about the interstitial pregnancies. The most important thing that we need to understand is the interstitial portion of the tube is the one which is about 0.7 millimeters wide and 1.2 centimeters long. And it is encircled continuously with thinning layer of myometrium. So that is the reason why whenever there is an implantation of a gestational sac, in this interstitial portion of the tube, it rests distended and thins the myometrium. So the thinning of the myometrium is basically because of the thin layer of myometrium which is already existing there. And remember, this is considered to be lateral to the uterotubal junction. That's very, very important. There is what's called as the uterotubal line that you can draw. So when you draw a uterotubal line, if whatever the gestation sacs, which are uterotubal line is the line which is drawn from the junction of the tube to the uterus, a vertical line is drawn, and medial to that is considered to be an intrauterine pregnancy. Lateral to it is considered to be the extrauterine or an ectopic pregnancy. Now, instead of that, it becomes much more easier to understand that whenever there is a breach in the endomyometrial junction, you call it as an ectopic pregnancy, because by definition, ectopic pregnancy is nothing but a breach in the, nothing but the implantation of an embryo other than the endometrial site. So keeping that in mind, remember that whenever there are gestational sacs which are implanted within the endometrium, that is medial to the uterotubal line, we call them as eccentric pregnancies, because these eccentric pregnancies, such as the eccentrically located normal intrauterine pregnancy, they develop into normal pregnancies and they have a good outcome. Whereas an interstitial pregnancy, which is lateral to the uterotubal line, definitely will have an abnormal outcome or is considered as an ectopic pregnancy. Now, we need to understand the coronal pregnancy. There are terms, these are the terms which are very loosely used. We should remember very clearly that angular is nothing but implantation of a gestation sac in eccentrically located normal intrauterine pregnancy, whereas a coronal pregnancy is the one where the blastocyst is occurring in one horn of the bicornuate uterus or one half of the septate uterus, Hence, this is a pregnancy which is occurring in an anomalous uterus such as unicornuate or bicorporeal or aseptate uterus. Hence, angular and corneal uterus are not considered as ectopic pregnancies because they are associated with implantation within the endometrium. So, for example, to make things much more clear, we have these images which are very, very clearly depicted. We know very clearly that this is the gestation sac which is actually implanted in the interstitial portion of the tube. This is a unicornuate uterus with a communicating horn, communicating rudimentary horn. And this is a unicornuate uterus with a non-communicating rudimentary horn. If the gestation sac gets implanted in this non-communicating or communicating rudimentary horn of a unicornuate uterus, you consider them to be an ectopic pregnancy. That is one. Two, when you have this sort of a bicornuate uterus or a septate uterus or an eccentrically located gestation sac, you consider these as normal intrauterine pregnancy because in a bicornuate uterus, in one of the cornu or one of the horn, where there is endometrium, the gestational sac is implanted. So there is no breach in the endomyometrial junction. So there is no reason why we should consider this as an ectopic pregnancy. So this is a normal intrauterine pregnancy. Only thing is that it is occurring in one of the horns of the bicornuate uterus. Similarly, if you take the septate uterus, if the gestation sac gets implanted in one half of the uterus, which is divided by the septum, again, it is implanted in the endometrium and there is no breach in the endomyometrial junction. So you consider definitely this as a intrauterine, normal intrauterine gestation because there is no breach in the endomyometrial junction. Whereas here you have this angular or whatever you call it as the eccentrically located normal intrauterine pregnancy, where you draw a utero-tubal line in that it is medial to it and there is no breach in the endomyometrial junction. Obviously, this is considered as a normal intrauterine pregnancy. This one concept I want to really put it across so that there has been a lot of confusion, a lot of misunderstanding and misnomers that have been going around where there is going to create a lot of chaos in our practice. So this is one thing which I was really, really particular to convey through. Now, second thing is, I think this part of it has been covered very well by, I would not take you through again all these things because he has already done. Now, one most important thing which I would like to mention here is that whenever we do a expected management in the interstitial pregnancy, there are two methods, strategies that we are going to follow as far as the interstitial pregnancy is concerned. One, when we think in terms of a local methotrexate injection, there are two things that we have to depend upon. One is the location of the interstitial pregnancy. Remember, if the interstitial pregnancy is closer to the myometrium or closer to the endometrial cavity, endomyometrial junction, it is always better to do an intra-sac methotrexate injection. Whereas, if it is a terminal part of the interstitial portion of the tube, that is the one which is prone to rupture. And that is the one which can be surgically easily managed. And those are the things that can be managed surgically. I think in order to give you a better opinion, idea, I'll show you the images, then you can understand. That is one. Second thing is, the most important thing is that faster recovery is required. Suppose most of these patients are assisted reproductive technique patients. So these are the patients who would like to conceive in their next cycle. So when they want it, if you inject a methotrexate into the sac or systemic methotrexate, then these are the patients who you need to advise them to avoid pregnancy at least for another 6 months. So that precious time cannot be wasted. So that is one more consideration which you have to keep in mind. Now you take these two examples. Here you have a very classical eccentrically located. You can see that there is a complete breach in the endomyometrial junction and it is more towards the tube. And you can see the yolk sac here. These are the ones which are prone to rupture, and these can be easily resected by surgically or laparoscopically. Whereas the ones which are here, where there is thinning of the myometrium, but it is much more inner, more towards the endometrium, in this situation, in case to do a resection of this, heavy resection of the uterus will be very, very difficult, and it's a very big process. So instead of that, you can nicely put the needle inside, and the possibility of rupturing this gestational sac is very, very rare. Whereas rupturing this type of a gestational sac is very easy. So this is the one which you need to choose to do an intra-sac methotrexate injection. So this is an extremely important concept that we have to keep in mind in managing these patients. So these are one of few examples of methotrexate injection into the sac, where you can see the needle tip and you place it, and then we can also inject this. See, this is the needle within the sac, and then you inject the needle. This is the one which you are injecting the methotrexate so that you can apply. Now, coming to the corneal pregnancy, as I said, corneal pregnancy is nothing but anomalous uterus. Quite often, when we call it as a corneal uterus, particularly when you have a hemicorporeal uterus, that is the unicornuate uterus with an empty cavity, and there is a presence of a rudimentary sac. As you can see here, this is the normal uterus, and that is the sac which is implanted with a gestation sac, which is a rudimentary horn, which is actually communicating. You can see it is communicating, whereas here you can see the sac, but it is not communicating with the horn. So this is what is called as communicating or non-communicating location of the gestation sac in one of the rudimentary horns is what is called as the corneal pregnancy. And most important thing here is the management of these corneal pregnancies has to be surgical. It is not to be done either systemic methotrexate or by intrasac methotrexate. Now coming to the low implantations. Low implantations, we have cervical pregnancy. Quite often it's iatrogenic, very, very rare. We have to differentiate it from a sac which is passing through the cervix, that is the miscarriage or imminent abortion. And then the nabothiensis, most important thing is in nabothiensis, no trophoblastic tissue around the nabothiensis. Not only that, it is not in the canal, it is in the stroma of the cervix. That is the reason why you can easily demonstrate that, differentiate it. Whereas abortion in progress, when you do a sliding sign, you push with the transducer. If it is abortion in progress, it can easily move. Whereas a cervical pregnancy cannot be slided because it is implanted and the trophoblastic tissue is infiltrating into the cervical canal. So these are the things that we have to keep in mind. Now, sonographically, what we find is that the sac is located below the internal os, and then there will be a living, maybe a living embryo or a yolk sac, and closed internal os, normal sized uterus but ballooned cervix. This is a very, very important factor. And at the same time, you will find that there will be a trophoblastic tissue. As you can see here, this is the sagittal section of the uterus. You have an empty cavity with the normal sized cavity, and you have a ballooned cervix with the hyperechogenic rim, which is actually the trophoblastic tissue. Put the color Doppler on, you can even see the cardiac activity within the cervical pregnancy. You do a 3D reconstruction, you nicely demonstrate that there will be a ballooning of the cervix. Now, these are the various cervical ectopic pregnancies that you can come across. This is the transvaginal examination where you find the empty uterus, gestation sac is located below the internal os, and there is a ballooning of the cervix. You do a 3D rendering, nicely demonstrate the ballooning of the cervix, and you can also see the cardiac activity in this one. Now, these are the things. The management are various methods. One, dilatation and curia, but then most important thing is they bleed torrentially. That is one of the most important things that we have to keep in mind. And other one is by using a balloon tamponade and then ultrasound guided needle aspiration as well as injection of the methotrexate. This is a classical case where you have a cervical ectopic pregnancy. You can see the gestation sac with the fetal node under the ultrasound guided. The needle is advanced. Once the needle is placed within the sac, you aspirate the needle, sac, and then put in 1 ml of methotrexate, which is almost about 25 milligrams of methotrexate. Then once it is aspirated, then you can see that the sac completely collapses. And but then remember, evaluation of total ablation or not is basically followed by doing beta HCG titers, not by doing ultrasound. This is one more aspect that I want to make it clear. And another important thing, as most of us, when we start doing this sort of a procedure, we should remember that after the first injection, that is the intrasac methotrexate, if you do a beta HCG titers within 24 hours to 48 hours, there will be a raise in beta HCG titers because the trophoblastic tissue gets ablated and that gets into the circulation. So there is an initial surge in the beta HCG titers, which gradually falls down over a period of time. That is the reason why you always advise to get a beta HCG titers after 72 hours after the intrasac methotrexate. Now, cesarean scar pregnancy. Remember, cesarean scar pregnancy is not an ectopic. That is one of the most important things I wanted to put across. The reason is, as we know, by definition, an ectopic pregnancy should breach the endomyometrial junction. That means the implantation should not take place in the endometrium. Whereas in a cesarean scar, basically, if you take the pathophysiology of a cesarean scar pregnancy, what happens is the endometrium is tugged or tethered into the scar tissue. And as there is a tethered endometrium in the scar tissue, when the implantation takes place, it gets implanted in that endometrium, which is tethered into the scar. So remember that as the sac has been implanted within the endometrium, we don't call this as a cesarean scar ectopic. We call it as a cesarean scar pregnancy. So that is one most important concept that you should remember. Second important thing is these pregnancies, scar pregnancies, can progress into an endogenous pregnancy or an endogenous scar pregnancy or an exogenous scar pregnancy. What do you mean by endogenous scar pregnancy? As I said, these are implanted into the tethered endometrium. They can gradually progress to become intracavitary lesions or intracavitary pregnancy. So when they progress to become intracavitary pregnancy, they will have a normal progress of a normal intrauterine pregnancy. That these are the things which are called as endogenous. Remember, all these pregnancies which have progressed to become endogenous are having the risk of placenta previa as well as placenta accreta spectrum. This is very, very important thing that you have to keep in mind. Whereas this exogenous variety is the one which progresses externally. As it progresses externally, it thins the myometrium and then it becomes the ectopic. And these are the ones which can rupture and cause torrential bleed. So that is how you are going to categorize this scar's pregnancy. So this is the concept that you have to keep in mind while dealing with this. For example, here you can see a niche in the anterior, that is the isthmus region. This is the bladder, that is the vesico-uterine junction, and you have a niche here. And you can see that the gestational sac is implanted into the endometrium, which has been pulled into the scar tissue. And this, in the same way, you can see here also. But then if you see, it is gradually progressing into the cavity. I'll show you some more examples where, of course, whenever you have a thing which is very, very thin, and you can see the bladder, you can see the myometrium is absolutely thinned out and it is progressing outside, and there is a increased vascularity with vascularity at the vesical junction also, which is highly suggestive of an exogenous cesarean scar pregnancy. Now, the diagnostic criteria is first and foremost thing that uterine cavity should be clearly visualized, cervical canal should be clearly delineated, there should be an implantation of the gestation sac in the lower anterior uterine segment, and that is the site of cesarean scar. And there will be thinning or absence of myometrium between the gestational sac and the bladder, and that is when you call this as an exogenous CSP, and the color flow shows between the bladder wall, intense color vascularity, abundant blood flow. Now, this is again, you can see that there is an empty cervical canal, you can see that there is an empty cavity, you have a scar here, and that is the gestational sac, and clear visualization of it. Whereas here, you can see that this pregnancy is progressing into the uterine cavity. So this is a classical cesarean scar, which is an endogenous scar pregnancy. And here we say the absent of the myometrium, which is an exogenous type of scar pregnancy. Now, increased vascular. Now, this is one sign which you need to understand very clearly. This is what is called as the crossover sign. The crossover sign is nothing but in a sagittal section of the uterus, you draw a line from the fundus to the internal os along the endometrial line. You remember, whenever you see an endometrium, you have the inner wall of the anterior myometrium, inner wall of the posterior myometrium. The summation of both of them will produce what is called as the endometrial line. You draw a line all along the endometrial line from the fundus to the internal os. If the gestational sac superior-inferior diameter is more than 2/3 above the line, I'm sure we are dealing with what is called as COS1, that is the crossover sign 1, and it is associated with severe complications. If we are dealing with a crossover 2 minus or plus, wherein you can see that almost 2/3 of it is below, but then 1/3 is definitely above into the scar. These are the things that which can progress into an endogenous ones. And here we have a thing which is absolutely progressed into the endogenous one. So whenever we have a cos 1, this is the one where you have a cos 1, where it is above more than 2/3 above the crossover sign. In that situation, there are a lot of complications like longer operating time, more blood loss, require more blood transfusion when compared to cos 2 and cos 2 minus and cos 2 plus. So these are the things that we have to keep in. These are very new concepts, not very new, but then concepts which we have to apply in our day-to-day practice. Now, differential diagnosis is cervical ectopic pregnancy, abortion in progress. We know how to diagnose a cervical pregnancy and abortion in progress, so I'm not going to take much of a time in this. Here again, you know that there is a ballooning of the cervix because the sac is implanted in the canal, whereas in the anterior isthmus, you don't find a sac there. There won't be any ballooning of the cervix, and this is the ballooning of the cervix 2D. And this is the abortion in progress, where you can see a nice internal os, and then you find the gestation sac below this one. If you use a sliding sign, you can easily move this sac up and down, which tells that there is no implantation of it. Now, these are the things that can be easily managed. As you can see here, there are two things. One, it can be a conservative management, systemic or local methotrexate, and not only that, you can use a balloon to compress this one and devascularize this sac, and that in that way also you can manage this ectopic pregnancies. Now, other sites such as the ovarian, which are extremely rare, 1 in 12,000. Here the gestational sac is located in the ovary. How do you know that it is a gestational sac? It is what is called as the elevated disc sign, wherein you find the trophoblastic tissue. And remember, the differential diagnosis is corpus luteum, and the management is laparoscopic resection. But the only thing is rarely conservative, particularly when one side ovary has been removed for whatever the reason it is. That is the lady is having a single ovary into which a gestational sac has occurred. As you can see here, this was the lady who presented with severe abdominal clinical features, very typical of ectopic pregnancy. Beta HCG titers were raising, and then you can see that is the ovary. That is what is called as the elevated disc sign. You put the color Doppler on, you do find the ring on fire appearance. Remember, but then this is not a cyst. This is a solid component. And not only that, you should have a thin rim in a follicular, the corpus luteal cyst, in which there will be a ring on fire appearance. Whereas here, you have an elevated disc sign, which is actually showing that increased vascularity. So these are the features by which you can differentiate a corpus luteum from ovarian ectopic pregnancy. Now, coming to the abdominal, very, very rare. Usually diagnosed late in gestation because patients are quite often asymptomatic, and occasionally they may progress into term. I had one lady who has actually been sent to me at about 32, 33 weeks of gestation, where I could find that it was in a very unusual presentation, very close to the anterior abdominal wall and associated with severe oligohydramnios. So these are the features which should prompt you to think in terms of a possible abdominal pregnancy. Of course, you need to differentiate between a hormonal pregnancy, which is usually mobile, whereas an abdominal pregnancy is always fixed, and the management is surgical only. So this is a classical example where you have a bladder, transvaginal extended view, or a panoramic view where you can see the cervix, uterus, uterine cavity, and you find the gestational sac. Fetus with placenta. There is no myometrium that has been demonstrated around it with the fetal node. So it's a classical abdominal pregnancy, which could be primary or a secondary. Now, heterotopic pregnancies, I won't be taking to you too much because already Anirudh has covered a little bit of it, in which quite often these are the things that are associated with assisted reproductive techniques. As he has already stated, the incidence is going up so rapidly. So the most important message I would like to convey here is, when we were students, we were told that if you demonstrate a gestation sac within the uterine cavity, we can almost rule out the possibility of an ectopic pregnancy. But then it is not anymore true. The reason is that if you demonstrate a gestation sac in the uterine cavity, it is your responsibility and duty to look for the adnexal region for any other ectopic pregnancy that could have been there. So it's a concomitant intrauterine and extrauterine pregnancy, which are called as heterotropic, and the incidence is increasing a lot with the assisted reproductive techniques. It can be anywhere. It can be in the tube, it can be in the cervix, it can be in the ovary, or wherever it is, or it can be intramural. So these are the various situations that one can find. This was a classical case where this lady was subjected to embryo transfer. One embryo was nicely transferred into the uterine cavity. The other two embryos, there were 3 embryos that were transferred. 2 embryos got stuck in the cervical canal, and they presented with the cervical pregnancy. And this, again, we did a nice transvaginal cervical ectopic ablation. Now, management is again a debatable. See, the most important thing in a heterotopic pregnancy, which is due to assisted reproductive technique, the patients are very, very anxious to continue the normal intrauterine pregnancy. And it becomes our responsibility to see and preserve this intrauterine pregnancy. In order to do that, there are various methods where surgical, again, associated with anesthetic or surgical morbidity. Antimetabolites like methotrexate is hazardous because it can cause systemic methotrexate toxicity. But then the best option was, at one time, was KCL injection. That is, aspirate the sac and put the KCL. But then you all know that KCL only achieves asystole. It will not ablate the trophoblastic tissue. That is one most important thing that you should understand. That is the reason why now there is a recent rich literature and a lot of papers are being published that the intrasac methotrexate is not going to cause any systemic toxicity. So that is the reason why now they have changed over to methotrexate, intrasac methotrexate injection. As you can see here, these are the 2 gestational sacs. Under the ultrasound guidance, I could introduce the needle, aspirate it, and put 1 ml of methotrexate. And this is the intrauterine sac post-ablation. Nicely seen that the cardiac activity is still present. So this is how you try to manage these heterotopic pregnancies. Now coming to the intramural, very, very rare, most difficult to diagnose. It's quite often iatrogenic because quite often when you try to do a termination of pregnancy, you can push the sac into the cavity, into the myometrium, and the differential diagnosis could be a trophoblastic invasion into the myometrium, and then management is conservative. Here you can see a young lady who came to me at saying that the beta-HCG, in spite of termination, beta-HCG titers were going up. When you see that there is an absolute irregularity of the endometrial cavity, and you can find a nice gestation sac with a yolk sac in the myometrium. When the color flow is, the Doppler is done, you can find that there is a trophoblastic flow. 3D reconstruction shows nice gestation sac which has been implanted or pushed into the myometrium. So this is the classical intramural pregnancy. Quite often you don't need to do anything because gradually the blood supply comes down and it gets ablated by itself. In case if it doesn't and the beta-HCG titers are still raising, then that is the time you can easily put in a needle and ablate the trophoblastic tissue by intrasac methotrexate. To summarize, the ectopic pregnancies are classified as tubal and non-tubal ectopic pregnancies. High index of suspicion is required to diagnose these ectopic pregnancies. Tubal pregnancies are commonest, typically managed surgically. Majority are managed surgically, as well as the local intrasac methotrexate in select cases. And heterotopic pregnancies, we need to preserve the intrauterine pregnancy. Now, this is a simple flow chart which one can follow whenever you have a problem. And so a lady comes to you with a missed period, as well as urine test and pregnancy test positive. Do a transvaginal examination. If you can identify an intrauterine pregnancy, then ask her to come for the dating scan, then the aneuploidy screening, anomaly scan, growth scan, and deliver. Whereas if you don't find a definite ectopic pregnancy or a probable ectopic pregnancy, first need to diagnose by taking certain biochemical parameters into consideration. If they are, so quite often, a word about this biochemistry. One is that discriminated zone is no more used. It is of no use now. Now, again, another thing is the ratio of 0 to 48 hours of beta-HCG is what is very important. But then again, remember that the raise in beta-HCG titers depend upon the initial beta-HCG levels. The lesser the beta-HCG level, the more the raise is. That's the reason why in 48 hours, expecting 66% raise is not really accepted. Only one factor is if there is a fall in the beta HCG titers by more than 13%, yes, we are very sure that we are dealing with a failing ectopic pregnancy. So if you do a transvaginal, you don't demonstrate the sac, search for the ectopic pregnancy, either in the adnexal region, heterotopic, uterine, that is uterine, lower level, fundal, as well as the scar and intramural. Management, methotrexate, systemic, intrasac, combination, and at the same time, TCL, laparotomy, laparoscopy, plus minus methotrexate. And in case if you cannot demonstrate either intrauterine or ectouterine or products of conception, retained products of conception, then you call it as PUL. And then the methodology followed is what is called as the M6 mathematical model that we are going to follow in identifying these PULs. Now, I'm very happy to extend an invitation to all of you for APSAN 2022 at Hyderabad in November 11th to 13th. Please do come, and because this is going to be a galaxy of international speakers. We have Ravi Choi, we have Ozan Hozan, and we have Simon Marr. They are all coming virtual, as well as online. On-site, we have Fred Hushkov, who is also going to come, and then we have Karim from Berlin, who is also going to give us a lot of talks on fetal medicine and gynecology. We have George Condios, who is going to talk on. He is an authority on endometriosis. Now, these are the registration fee. Please visit www.apsam2022.com, which gives you every detail about this APSAM program. Thank you very, very much.
Thank you, sir, for such an excellent talk. I think this is a very rare topic which you have made quite simplified and helped us for in the way of management also. Thank you so much, sir. I request Dr. Anjali Vare ma'am to give her expert opinion on this.
Swati?
Yes, ma'am.
Yeah. I think ma'am is busy.
Okay.
So, yeah, it was an excellent talk, sir. Practical tips has been given to you. In this era of subfertility, you have Aniruddha sir and you have, both of you have very well given us knowledge about how to conserve the fertility of the patient. Instead of doing a salpingectomy, how we can give the methotrexate injection both systemically and in the ectopic pregnancy itself, and thus conserve the fertility of the patient. That was a very nice talk, sir, and we are really thankful to you to give us such a good knowledge. Thank you, sir.
Sir, I want to ask only one thing about intramural pregnancy.
Yes, ma'am, please.
In intramural pregnancy, sir, while doing this evacuation or MR, means menstrual regulation with the cannula, this sac can be pushed in the myometrium.
You have seen the images.
Means
I have shown you the image where it was completely. Can you listen?
we are aspirating with the negative suction.
I know, but then you can see that there was complete distortion of the uterine cavity.
Okay. Means implantation was in the uterine cavity, and afterwards, doing the MTP, the sac goes into the myometrium.
I think, sir.
Yeah, am I audible?
Yes.
You are.
Yes, sir, you are audible.
Yeah. I mean, I have answered her.
Yes, sir. Thank you.
Okay. I think after the 3 excellent lectures, we should call off it as a wonderful and very knowledgeable evening. And on this, I want to thank our chief guest, Dr. Madhuri Patel Madam, our guest of honor, Dr. Rajendra Singh Pardesi Sir, Dr. Kiran Karkoti Sir,
Dr. Sujit Konkar sir, Dr. Vaishali Surase ma'am, Dr. Anjali Vare ma'am, and lastly to our excellent speakers, Dr. Sujit Konkar sir, Dr. Aniruddha Kulkarni sir, and we are privileged to have you here, sir, Dr. Praveen sir, for their wonderful presentation. I thank you so much, Dr. Stelin and Shield Healthcare for their educational support, and to all participants to give their valuable time for this webinar. And I request Dr. Sujit sir to organize such a kind of webinars which are rare and which we really need to highlight the details about such kind of webinar. Thank you. Thank you, everyone.
Thank you.
Thank you, ma'am. Thank you very much.
Thank you.